analysis and semi-quantification with gated SPECT and SPECT-CT. For the workflow in SPECT imaging, we start by the acquisition, and of course, the most important thing is the processing. And for the processing, we have different steps: the motion correction, the reconstruction method, the filtering, and finally the reorientation, which is very important. And of course, in the workflow, after the processing, we have the reporting. For the correction and for the correction of orientation, this is very important for the two conditions, stress and rest, because we have to start on the transaxial slice and to make the good correction and the good reorientation for the stress and for the rest, and to check each images for the stress and the rest. For example, this is the classic result screen from the apex to the base and from stress and rest condition for one patient. And we have to check every images from the apex to the base for the short axis, but also for the horizontal axis and for the vertical axis. And again, we have to describe the different defects from each images, but also to get the color bar, because the scale is very important. We have to check by two scales. Sometimes maybe it's what we call, gray or black and white, or maybe the cool images. And it's very important to get this kind of linear scale to be sure that we have some defects and not another thing. For example, this is for the image analysis, what we call the visual analysis. It's very important for the microperfusion imaging. And this is a comparison from stress to rest. And we have to check image by image. In some countries, we can make some what we call a database from the normal population. But sometimes it's very difficult because the BMI are not very identical from the US, from Europe, for example. But sometimes it's useful by gender, by weight-adjusted normal findings. So this is good for the brain, but sometimes maybe good for the heart. And we have to check, again, the scale for the images from the stress and the rest. But from the visual analysis, now we can move to the quantitative analysis. Maybe semi-quantification is better. Why it's important? Because for the clinician, for the cardiologist, they want to check, the different modalities, echo, MRI, and nuclear cardiology. And they know exactly how to detect, what we call the 17 segments on the left ventricle, from the apex to the base, and also we can check the apex, what we call the segment 17. Why it's important? Because we have to define in each segment the tracer uptake. And then if, for example, you have a normal tracer uptake, we can make 0. Or if you have no uptake, in fact, this is 4. So then we have the grading, and we can make, again, a scoring. Not only with the perfusion defects, we need also some data from the gated acquisition. Gated acquisition is important because we can make volumes, you can get ejection fraction just after stress, just after rest. And then we have to check the volumes and ejection fraction. Why? Because sometimes we can detect important finding like stunned myocardium. So maybe it's just after the stress, you have some stunned myocardium with hypokinesia, just the global hypokinesia of the left ventricle. So this is, again, incremental additional value of MPI is the gated with ejection fraction. Anyway, for the tracer upcheck, we can make, a score. And this is very helpful sometimes for what we call the sum stress score just after the stress, or the sum rest score just after the rest. And finally, the difference between stress and rest is what we call the sum difference score. And then we can define some patient with very severe patient with maybe with big infarction or big ischemia, or sometimes normal patient with 0. So then, again, on your report, you can make this kind of information with some stress score, some rest score, or some different score. This is an example. The patient with, again, detection for coronary artery disease with its sestamibi, and we can see on the top the stress, and then we have the rest, and we can check from the short axis and horizontal and vertical axis. And finally, this is a normal perfusion, normal visual analysis, but also if you can make, the uptake, you can say it's 0 for the stress, 0 for the rest, so it's a normal perfusion and it's perfect for the patient, no ischemia. In contrast, with this patient, the patient, came for detection of CAD with sestamibi, and you can see on the short axis, but also in the apex, a very severe, defect, means on the stress and rest, infarction. So this is a severe patient because the SSS is high, and also the rest is less than the SSS, means you have infarction and also ischemia. So it's a severe patient, maybe go to the cath lab. Another example with a severe infarction on the anterior wall, and then we have no ischemia, but again, the patient with dilated cardiomyopathy, we can see also the right ventricle means it's a right dilation. So this is, again, the high score of stress, high score of rest means severe cardiomyopathy. Why it's important to get this quantification? It's because based on, the number of segments of the LV. And then if you have 2 segments, means 10% of the LV damage by ischemia or maybe infarction, you can change the strategy. You can change the therapy. Maybe just medical therapy. Sometimes you need to push the patient to the cath lab to make revascularization, to make stenting, or maybe CBJ. Means, again, is for that in your reporting, it's important to note the percent of LV damage by, the stenosis. So 10% is 2 segments. Very important message. Finally, this is reporting for the nuclear physician, and maybe it's feasible with the cardiologist is better. Why? Because in fact, what do we need in a clinical referring, report? I mean, it's a report. The report should be short, should be precise, should be clear for the clinician with the statements of the diagnosis. Means, ischemia, infarction, both, or normal. And sometimes you can push also on your report the prognosis on the stress acquisition. And finally, in some cases, it's possible to push, in fact, the patient and to push the clinician to another strategy to say, now we need cath lab, you need more aggressive investigation by angiography, and maybe the patient needs, PCI, or maybe stenting, or maybe CEBG if the ischemic pattern is very high. So this is, to my mind, the very important report to do for the clinician. Thank you for your attention.